My name is Rebecca Shatsky, and I am an associate professor of medicine at the University of California, San Diego. So today I presented a summary of 4 abstracts from ASCO22. I talked about updates from the KEYNOTE-522 trial in triple-negative breast cancer, specifically the event-free survival as categorized by the residual cancer burden that was presented by Lausch Pustai of the Yale Medical Center. We talked about how it was found to be that in patients with RCB, not just 0 and 1 that benefited from the addition of pembrolizumab, but also specifically patients with RCB2 status, and it does hint that there may be benefit to adjuvant pembrolizumab in this patient population, which has been a big question going forward. I also spoke about the ASCO22 trial, which was a large trial that looked at the benefit of chemotherapy in geriatric patients above the age of 70. It used a genomic grade index, which was a novel genomic scoring system to look at high versus low risk patients genomically and see if they benefited from the addition of adjuvant chemotherapy to endocrine therapy. This trial found that overall survival, there was no statistically significant difference between the patients that had genomically high-risk disease and received adjuvant chemotherapy in addition to endocrine therapy versus those that received endocrine therapy alone. There were also several grade 5 events in the addition of the chemotherapy group. So it begs the question of, in this specific patient population, how we select the patients that we choose to give cytotoxic therapy, and whether we need to be a little bit more cognizant of whether these patients are actually benefiting in the long term. I also spoke about the NEOPAC trial presented by Priyanka Sharma from the University of Kansas. This trial used a non-anthracycline regimen of neoadjuvant chemotherapy for early-stage triple-negative breast cancer. It was patients with stage 1 through 3 disease, and it used a combination of docetaxel, carboplatin, and pembrolizumab given every 3 weeks for 6 cycles. It found a pathologic complete response rate of 58%, which was similar to other neoadjuvant immunotherapy containing regimens for triple-negative breast cancer. Some patients who had poor response were able to receive anthracycline salvage therapy adjuvantly as well. So it presents a new option for a non-anthracycline regimen for early triple-negative breast cancer. Finally, I discussed an abstract that looked at alternative dosing schedules for the drug exemestane in the pre-surgical setting. So it was a neoadjuvant pre-surgical trial that looked at specific blood and tissue biomarkers and saw how alternative dosing regimens of exemestane, specifically Q-day dosing, 3 times a week dosing, and once a week dosing, affected several biomarkers, including estradiol levels, estrone, and total estrone. It found that 3 times a week dosing of exemestane was quite similar to daily dosing, which presents kind of a hypothesis-generating study that maybe this could be a potential alternative dosing regimen in patients who are either have at high risk for disease, have high risk DCIS potentially, or those who have invasive disease who have very significant toxicity and are unable to tolerate either other aromatase inhibitors or daily dosing schedule.